honest, since the gathering is diverse, I shall be using some common words which are not very friendly to the non-medical fraternity. So here we go. So diabetes, as we know, is evolving and it is increasing every single day in India. And to be very frank, if we look at the demographic profile of diabetes in India, approximately 20% of population more than 40 years. Two types of this is something which is called pre-diabetes, that is people who are supposed to get diabetes in next 5 years or so at the rate of 5% per annum. So very frankly speaking, the persons who are diabetic, their offsprings or their kids are at high risk of getting diabetes in the future. So diabetic neuropathy is a common macrovascular complication of diabetes mellitus, and in that diabetic autonomic neuropathy, which concerns about your subconscious controls of the body, is something which is affected in a long-standing diabetes. So diabetic gastroparesis is one of the important complications of diabetic autonomic neuropathy, which is the talk of the town for today. So before I go, I shall acquaint you with the normal gastric motility, how your stomach works when you eat meat. So this is a very simplified diagram which is depicting the stable stomach. You have to have a intact enteric nervous system that is within the stomach wall, and you need to have a. So somehow, if these three elements are affected, the gastric motility gets disturbed. And of course, you require smooth muscles of the stomach for the contraction. And this is substantiated by funding tone, which is there, every single moment. And there is enterophasic contractions of the stomach, so the food can go from this to this. This is a normal path for the meal once you take anything orally. And of course, this is has to be in addition to the inhibition of pylorus. This is the pylorus, so it has to be inhibited so that effective contractions can take place. So this is a cartoon that will tell you about how to do. Can you play the video from there? Yes, it's not. So this is a simplified video.
Even before we've taken the first bite of a meal, the brain sends impulses to the stomach. These impulses start the production of secretions in the stomach, and the upper part of the stomach, which acts as a reservoir, expands. The food passes into the stomach through the cardia at the stomach entrance. This is a muscle that acts like a valve, closing the top of the stomach. The top part of the stomach, the fundus, is where food and the air that we swallow with every bite is collected. This is where the stomach volume starts to adapt. The fundus is an extremely adaptable structure. The more food goes into the stomach, the more it actively expands. In the middle part of the stomach, called the body, gastric juice is produced and mixed with the mass of chewed food. The main component of gastric juice is gastric acid. This eliminates bacteria in the food and also helps to prepare the food for the following stages of digestion. The muscular contractions of the stomach wall churn the food mass and mix it with gastric juice. 3 contractions per minute move the food mass back and forth. After a certain time, the contents of the stomach are adequately broken down and mixed and are passed in small quantities into the intestine via the pylorus. As the stomach empties, it gradually returns to its previous size.
So this is a small part to a huge, massive stomach. So how the patients will present, that is the big question. So most of the patients who are suffering from gastroparesis, they will complain of early satiety. So they will complain the moment they eat something. They feel as if they are done. They are not able to take any more meat. They are unable to finish their portions as they used to take earlier. And some of them do have nausea, early satiety, abdominal pain, and most importantly, when the symptoms become severe, there is a history of weight loss, malnutrition. There may be epigastric distension, tenderness. Occasionally, this is a clinical examination finding where you find a succussion splash by clinical examination. The severity of gastroparesis, mild, moderate, and severe. So they basically are divided into 3 parts. One is the nausea and vomiting, early fullness or relying in our center on gastric emptying scintigraphy. which is a radionuclide imaging basically, which is done with technetium 99. So this is a typical example of gastric emptying scintigraphy. You can see the decay time of this technetium 99 radio level meal. We typically give idli meal or a liquid meal to this patient, and then we scan over 30 minutes, 1 hour, 2 hours and 4 hours. And the normal gastric emptying must be 60% of meal retention at 2 hours and retention less than 10%. That is, the total nuclear scan material or radionuclide material should be emptied by 90% after 4 hours, or at least 60% in 2 hours. If it's not happening, it means the food is retained in the stomach, and this is the diagnostic part of diabetic gastroparesis. So so this is a classical patient of diabetic gastroparesis or gastroparesis otherwise as well. Now, management of diabetic gastroparesis has few caveats. There is no consensus regarding optimal management as of yet, and there is dietary modification. The first line of treatment, we ask the patient to have small frequent meals and don't indulge into overeating of salads. Salads are contraindicated in these patients. If they take salad, then they may go into obstruction as well. So the only drug which is FDA approved is important. The PPI or the antacids are absolutely dangerous in diabetic gastroparesis patients because it can alkalinize the acidic environment in the stomach and lead to bacterial overgrowth syndrome. So the identified problems are they have poorly sustained effect, adverse effects are absolutely there. There is a need to take for a longer period, and probably there is no cure as of now for diabetic gastroparesis. There are recurrence of symptoms after drug is discontinued with the potential to revert diabetic gastroparesis with long-standing effects and minimal side effects, for which we did a trial on mastic gum. Mastic gum is Pistacia Lentiscus, and this is a Chew's mastic gum which we imported from Greece, and we extracted the material from Medicine Agency with 2 therapeutic indications: mild dyspeptic disorders and skin inflammatory or healing for minor wounds. In a pharmacopoeia, its use are very well described. That's the reason why we chose this for research purpose. So why the Pistacia Lentiscus could be of use in the diabetic gastroparesis? Because it consists of pipines and terpenes, mainly alpha and beta terpenes, which has a very remarkable effect on the motility of the stomach. And also, D-limonene present in Pistacia Lentiscus improve gastric inflammation, and inflammation is one of the contributory factors in the causation of diabetic gastroparesis. So that is the reason why we chose, and there is olenolic acid which is important in insulin synthesis, and hence it portends a better control of diabetes in the already existing drugs that were given. So this is a cartoon that is the showing the effects of Pistacia on various receptors and molecules. And at this point of time, I'd like to emphasize this M3 muscarinic receptor action by the Pistacia Lentiscus, which helps in muscular contractions at various places, especially smooth muscles. And there is enhancement of GLP-1 receptor release by agonist action, and hence it has a better glycemic we're talking about. And this was done. This is the baseline. This is the baseline study on which the subsequent study is planned. We already had head-to-head comparison between Pistacia Lentiscus plant in comparison to levosulfide. Levosulfide is one of the prokinetic agents with less side effects but more sustained actions. So it was found to be non-inferior, approximately 170 or so, and we excluded them because some of them were not really normal gastric emptying scintigraphy, hence they were excluded from the trial. We randomized them on the basis of the computer randomization table, and we had 20 patients on the levosulfide arm and then 19 patients in the. So let us discuss the results. If we consider the demographic profile of these patients, age, sex, gender distribution, male-female ratio, they were almost equal. They also were equal in glycemic control as well as the no difference. P-value was not statistically very significant. So this is levosulfide arm A. This is Pistacia Lentiscus, basically significant reduction in the T half of the gastric emptying. Earlier it was 180, then this is the line diagram depicting the graphical presentation of change in 4 hours emptying. So
the group A, was the mastic gum, and group B was the levosulpride. So they were equally faring because levosulpride is available and tried. That's why we took this drug as a comparator. And after 8 weeks, the trial was stopped, and you can see this is the post-intervention GCSI score from 36, it came up to 20 after 1 month, and then approximately 18 after 2 months. Till this time, we were giving B, which is mastic gum, was having sustained effect on GCSI. Symptoms were really not there. Whereas the levosulpride arm started having the symptoms again after 2 months. And these patients required few more agents as a prokinetic agent to alleviate the symptoms of diabetic gastroparesis. Whereas Pistacia lenticus did not require any other added drug. So the p-value at the 24 months was really very significant. There was hardly any difference if you look at the pre-intervention. Approximately added prokinetic agents out of 90 was significant difference in the postprandial fullness and release satiety. And there are a few more trials which have, and this has been found to be effective in Crohn's disease also because of anti-inflammatory action. Soluble in oil. So this is not a very hydrophilic molecule. No long-term adverse has been noticed. This is already approved by EMA, and biochemical safety has been in all clinical trials. This is my patent molecule, and I got this patent in 2023 for issues including adverse effects and non-sustenance of therapeutic effect. Pistacia lenticus is the highly effective and superior to currently available treatment for diabetic gastroparesis. Almost this is a cure for diabetic gastroparesis. This is used and this is usually given twice daily or thrice daily. With this, I thank you all.